Welcome, everyone. Thank you for joining us for another edition of our Native Strong Weekly Town Hall or bi-weekly Native Town Hall on the COVID-19 pandemic and the ongoing response, vaccines, how we're dealing with it, all of that good stuff. We've got a lot to get into today, so I'm going to try and keep this little intro short. As for those of you who have joined us before, we love questions. We appreciate your questions. So please ask those either via Zoom in the chat bubble at the bottom of your screen, or if you are joining us via Facebook Live, please drop in a question as a comment and we'll moderate those and get to those at the end of our session here today. Big topic of conversation will definitely be boosters today. So if you have questions, I know I do, please stick around and we'll try to answer those as we get in through our session today. And as per usual, our featured speaker, Dr. Lyle Ignace of the Gerald L. Ignace Indian Health Center is here with us today. Once again, so I'm going to pass it off first for a little intro as well from our moderator, Mark Denning, who's joining us once again. Thanks everybody for being here, and thank you, Mark, and thank you, Dr. Ignace.
Buju, Nadawe Benezi, Indigenous, Namaendo Dem, Anishinaabe and Dao, Neopit, Indonjapa. So welcome everybody. Mark Denning here, in part of this Milwaukee community on an amazing day. If you're a teacher tuning in to learn about COVID-19, awesome. We do have a lot of them that tune in after the show is done. So welcome to you on our tape delay. And also on this day, it is Orange Shirt Day in Indian country, both in the United States going south and certainly up into Canada. And that day, for folks that don't know, is a day that is reserved for consciousness and awareness raising, not just for us as Native people, but also for our non-Native friends. In a lot of what today is the remembrance and the celebration of survivors of the residential schools in Canada and the boarding schools here in the United States. So at many Native schools, at many public schools and private schools throughout Wisconsin and other areas, a lot of young people and teachers are wearing orange today. You'll see it in stores. I saw it just a few hours ago. I was out in a couple of stores. I saw Native people, usually not visible, but I saw them wearing their orange, and it was just awesome. Behind me on my right or your left as you look at the screen, you'll see a shirt that says children are sacred, and then my traditional vest that I have, and a shirt that was sewn for me. And so reflecting on today is very important. The learning that we need to do about these boarding schools and what had happened, because there are echoes of that throughout the next few generations. And one of those echoes certainly is why we're here today. And that echo is about our health, not just mental health. For the moms and dads out there that worry about kids going into school, what's that look like? I think the numbers are coming in now that school has started. What do I do? How do I go about it? What's happening out there? Is there another variant? Sometimes instead of having fear guide us, it should be information. And that's why I am glad you're here. I think that's why we're glad you're here. And thank you for being with us. So a very good and healthy Orange Shirt Day to all of you Native relatives and allies. Thanks for recognizing this day. And also, we have some very important things coming up that we'll learn more about later in the program. So turning this over to you, Dr. Ignace. Looking forward to today's show, because I think there's a lot of grandparents, guardians, parents wanting to know, hey, what's going on out there and what's being learned now that school has started. Dr. Ignace?
Thanks, Mark, and thanks, Jeremiah. There's a lot of stuff going on, and I'm going to try to go through it as efficiently as I can. But I first want to make an announcement. The Gerald L. Ignace Indian Health Center is going to be sponsoring an event that's coming up November 5th. And as you can see on this slide, it is the Honoring the Heartbeat Mental Health and Wellness Mini Powwow. Now, our traditions, our cultures have many facets and ability to help us, not just mind, body, and spirit, So it's going to be important, and this will be our first event that we are hosting coming in this pandemic to this scale. So in honor of Native American Heritage Month, we will be hosting this event at the Potawatomi Hotel and Casino. And the caveat to assure that safety, the health of everyone that attends, we are requiring people to show proof of vaccination or a negative COVID test within 72 hours of the event. So I am encouraged by us being able to host this event on a scale that I think that will be safe. It will be in a controlled environment, and at least assure the safety and the prevention of any transmission for everyone that will be participating who wants to. So please, this will be on our website, on our Facebook, and we'll certainly be able to address any questions as it comes, and we'll post more information as we get closer. But November 5th, keep that in mind as we move forward. So this could very well be re-engage in our traditions, and in honor of Native American Heritage Month, we'll be hosting this event. So with that being said, let me get into a lot of what has occurred in the last 5-7 days. Now, as you recall, on September 20th, the president had made an announcement that boosters were going to be available for most Americans, and at that time it was based on age, 12 and older, starting September 20th. Now, a few things had to occur in this whole process, and this is really based on health decisions for the country based on the FDA and the CDC. And so we've had these two advisory groups to the FDA and CDC come out, and they came out with pretty much in alignment with each other. However, there was a twist that occurred, and I'll go through that in a second. So now, 2 weeks ago, I had presented what the UK was doing, and this was their outline of boosters as far as their recommendation. So individuals that resided in care homes, frontline health and social care workers of all ages, 50 and older, and conditions that placed them at higher risk, and adult household contacts of immunosuppressed individuals. That seemed pretty straightforward, and I think a lot of what the current medical literature would actually support and suggest. Well, as you know, the FDA had met, and their advisory group actually made these kind of agreements to who, based on the evidence that they had and the literature to support any individual over the age of 65 and any individual between 18 and 64 years of age at high risk of severe COVID. So that was the main focus, was identifying age risk groups as well as individuals with high risk with underlying medical conditions. That was the FDA. FDA approved it, moved on. CDC advisory group came on. They were next up, and they really agreed pretty much the same way. People 65 and older and nursing home residents. Okay, sounds like the UK model, as well as 18 to 64 with underlying health conditions that raise their chances of severe COVID. Now, obviously, this was only based on the Pfizer vaccine. So the question is, as it went to the CDC director, things changed. So now, going off of what the CDC went further on to individuals 18 to 64 whose frequent institutional occupational exposure to COVID puts them at a high risk complication, including severe COVID. Now, this is a new language that was put in, and it was decided in the wee hours of the morning when everyone was sleeping. And so there's a few things that come into play here, and what qualifies as frequent institution or occupational exposure, and what actually what is the actual definition of underlying health conditions. So, and that wasn't really explained as to how this was going to come about. So here are the qualifiers for boosters for underlying conditions. So essentially anybody who has a diagnosis of cancer, CVD, cardiovascular disease, chronic kidney disease, COPD, lung, diabetes 1 and 2, coronary artery disease, congestive heart failure, hyperlipidemia, smoker, current or former, obesity, pregnancy. You're hearing a lot about pregnancy in the last couple of days, or even recent pregnancy within the last 42 days after delivery. Children with underlying conditions, liver disease, Down syndrome, HIV, neurologic conditions, and very specifically with dementia and Alzheimer's. Overweight, this is kind of a touchy definition here, because individuals, if anybody who's gone to the doctor and you've been told what's your BMI, body mass index, anything over the 25 is considered to be overweight, which puts you in that category of underlying condition. Lung disease, sickle cell, organ transplant, substance abuse, whether it be alcohol, opioids, cocaine, use of corticosteroids, asthma, and hypertension. So this is kind of the very broadest definition of what makes you qualified as having an underlying condition. Now, what I also thought was kind of interesting is who's at high risk. Well, you could pretty much make a case that everyone is high risk. We're all exposed at some point in time, not just at our work, whatever work that may be, but also in our public lives. As we just travel from place to place, there's always a risk of exposure. So I had to look this up because the CDC comes out and says, well, 18 to 64 who work or reside in certain settings like healthcare settings, that would make sense, hospitals, urgent cares, clinics, schools, correctional facilities, homeless shelters are also part of this definition. So now they do qualify that risk varies across different settings, in public settings and hospitals and any work situation. And so I tried to find something a little more defining as to what this may be. And this is as best as I could get. So individuals' occupations, first responders, healthcare workers, firefighters, police, congregate care staff, education staff, teachers, support staff, daycare workers, food and agriculture workers, manufacturing workers, corrections workers, postal workers, public transport, grocery store workers. It pretty much includes a pretty wide swath of people from all walks of life. Now, does that necessarily mean that you have to get a booster? No, but you certainly are eligible. I think the people that are at the highest of risk are certainly individuals with underlying conditions. And so, confusion as to who does and who doesn't, or who may be eligible. In this list of occupation, I like how they put this caveat down here. this could be updated in the future. Well, you can pretty much bank on this being updated, and this will continue to be added. New occupations will continue to be added on this. And so overnight, what I think most healthcare providers and public health officials were kind of wanting to get guidance on this seemed pretty well defined. By the next morning, though, everything got flipped and all these new additions were added. And the concern about all this is that it really comes down to people self-attesting to their eligibility to get Pfizer. Now, Johnson & Johnson's not part of this. Moderna's not part of this. It's just individuals who've received the Pfizer vaccine. So it does put a few wrenches in the wheel here. And this is something that we're going to have to figure out. And while we were all ready to go the next morning with a certain mindset of what's going to be eligible, now we have additional lists that have to be taken into consideration. So there's going to be some confusion up front, and there's going to be some outlining and guidelines, recommendations set forth, and it's going to take a good minute to get these outlined. So there won't be any confusion for individuals who want or need to be boosted with additional shot. Now, there is upside. What's going on globally right now is that new COVID cases and fatalities continue to decline globally. WHO has come out with their weekly report update citing new infections. However, these new infections across the world are dropping, has dropped by 10%, not only in cases, but also in fatalities. So that is certainly a good sign that the current COVID-19 variant Delta has peaked and perhaps on the declining, certainly as WHO has listed out here. The biggest drops in cases we're seeing in the Eastern Mediterranean area, as well as the Western Pacific and the Americas, believe it or not. Here in the United States, it is decreasing. So just to give some other highlights, what's going on, I've been hearing more and more literature being published on Johnson & Johnson. Their clinical data trials when they first came out showed that 4 weeks after shot, it was 66% effective against COVID and 85% effective at preventing severe or critical disease. Now, that's been pretty much the case. The upside to Johnson & Johnson was that it was a single dose. Now, as far as updating most recently of September 21, Johnson & Johnson came out with another follow-up study looking at March to July of 2021. Their vaccine did not show any diminishing of their immunity, and that their single dose was actually 79%, looking at real world data. So, okay. Now, what's kind of interesting, what's come out as a follow-up to this is that when it came to their booster trial, giving a second dose, given 2 or 6 months after the first, protection against moderate or severe disease increased from 85 to 94%. So, while it may not have shown a very high comparable effectiveness rate to Moderna or Pfizer when it first came out, giving a second shot, or they call it a booster, but essentially a second shot after the first, showing that to be about 94%, which makes you kind of wonder, should Johnson & Johnson have just come out with a 2-dose regimen to begin with? I think their efficacy and perhaps their uptake in the country and worldwide may have gone up a lot more if it maybe produced or at least announced or promoted it as being a 2-dose series. but it has been shown to be effective and quite comparable to what we were seeing in Moderna and Pfizer. So that's coming. So other items that are coming up on the horizon. So we're hearing a lot of comments, public health or literature is coming out on children's vaccinations, and getting Pfizer's is ready, if not already have done submitted data to the FDA to look at emergency use authorization for kids 5 years to 11. In fact, I'm sorry to say, September 28th, they actually did submit data. They're looking at a 2-dose regimen, 1/3 the dose of adults, and their data has shown to be quite comparable to adults in its effectiveness. Now, when is that coming out? We don't know. We can't predict how fast or how thorough and how long it will take for their advisory groups to get together and actually decide on when this is going to happen. But it's quite possible that vaccines, Pfizer vaccines for kids, could come out as early as Halloween or as late as Thanksgiving. So within that time frame, vaccines will become available for kids 5 to 11. So that is actually very encouraging news to hear, and I'll go through why that is, and I think everyone probably knows why that is right now. Now, as far as mixing boosters, whether you get Pfizer, can I get Moderna? If I get J&J, can I get Pfizer? And back and forth, can you switch between vaccine? And the general sense right now is that it is not recommended. It is not recommended. You stay with what you started. Only because there hasn't been enough data to suggest of mixing of vaccines. The efficacy has not come out with that. They're studying it right now, but there hasn't been an official recommendation based on its safety or effectiveness. So that's going to be a pending decision moving forward, whether or not you can switch out, from different vaccines. So I wouldn't do it right now, especially switching from one type of technology to the other. So very specifically, I'm not recommending someone who got, let's say, Johnson & Johnson, switch over and get Moderna or Pfizer. Those are different technologies that are based on developing the vaccine. I think the bigger question is, and what has a much higher prevalence of use, is the mRNA vaccine, Pfizer and Moderna. I bet there will be some encouraging news on you can switch Moderna with Pfizer. I mean, that's certainly possible, but we'll have to wait and see. One thing I haven't really touched on much up to this point, we talk about vaccines, we talk about hospitalizations and severe of illness. Things that are kind of interesting as an outpatient treatment for COVID, and it doesn't really get a lot of traction. But there is one particular therapy, monoclonal antibody treatment. Now, these are very specific. These are usually done in infusion clinics. There's a referral process, and there's a lot of confusion as to who is actually eligible to actually get this type of outpatient treatment, because this is really designed to help individuals who are at risk, who have disease and progression of disease. But if we're looking at trying to keep hospitals admissions down, or ICUs, or illness and fatalities down, this is one effort that could be done as an outpatient that providers know of, and in clinics that are set up to do this. Now, who's eligible for this? Basically, or more typically, the individuals who do get accepted and get treated with monoclonal antibody are usually ages 65 and older, or individuals with high risk conditions that are progressing in their illness. So you want to catch people before they actually get too sick to be admitted to the hospital. This would be one option, and it has been shown to be quite effective in keeping people out of the hospital. Other things that are coming down the pipe. So there's oral medications for flu, COVID that are coming out. People may have heard about Tamiflu. Tamiflu is an antiviral, which was used to help people who've gotten the flu. I've gotten the flu once. I was on call in the hospital. I came down with sudden fever and knew I was coming down with the flu. I was prescribed Tamiflu, and I was able to keep working that weekend. And my fever broke within 24 hours, and my course of illness was actually shortened quite dramatically. Same thing for COVID. They're looking at an oral medication to treat as an outpatient that will reduce severity of illness and the duration of illness as well. So much like what Tamiflu does for the flu, a COVID antiviral is also being developed right now. Clinical trials on nasal steroids for treatment with long haulers with decreased smell. They're looking at these trials right now and accepting individuals to enroll. And the general sense is that this can actually help improve individuals who have had long-term symptoms. So there's other antiviral combination medications that are being developed out there right now. And so these are all encouraging and important studies that need to also be included in discussions, because, you know, at some point as we come out of this, there will still be cases, there will still be individuals who will get sick, but if we have more tools to treat early on in early onset of disease, we could actually start looking at how we are preventing hospitalizations, even outbreaks, with early diagnosis and outpatient oral medication. So these are encouraging studies that are coming that are going to be important in how we manage this, much like how we manage flu as an outpatient. So I know people have talked about other variants that are coming that have been spoken about. So we know about the Mu variant, the B1621. This is the variant that came out of Colombia. Now, what's kind of interesting right now is that we're not hearing much about this here in the United States. And the reason why that is Delta has pretty much taken over everything. Delta has been shown to be quite contagious and easily transmissible, and has essentially overtaken any other variants of COVID to this point. And when that happens, it really becomes survival of the fittest, and this virus pretty much dominates everything. So if you're going to get sick, Delta wants to make sure you get sick from Delta, not from Mu. That's the only way it can propagate in public, is if it overpowers or overtakes communities and outpaces the other types of variants. So we may be seeing the Mu variant be squeezed out of existence. And there's another possible reason why that is too. So according to outbreak.info, they're not seeing any new cases of Mu variant, which is good. That's good news. We don't need another variant to take the place of Delta, but it's really has shown a dramatic decrease, not just here in the United States, but also worldwide. And so this is really encouraging news. And another reason why this may be occurring is so a group of scientists out of Japan is going to be publishing a paper that found that vaccine, the Pfizer vaccine, seems to have an adequate effectiveness against the Mu variant. So we have two competing things going on at the same time. One is we have a world population being vaccinated, okay? And we also have the Delta variant, which is predominant infection right now globally. Two things going at the same time. And while people are vaccinated, are protected, fairly well protected against the Mu variant, we have Delta squeezing variant out of existence. So we may end up seeing these two big main variables, maybe the main reason why Mu is being squeezed out, and hopefully not to be an issue moving forward. So I don't think we'll be hearing much more about the Mu variant moving forward, because everything right now is all about the Delta virus. So I did want to mention a little something about the long haulers of COVID. Oxford just came out with a study looking at a fair amount of people, almost 275,000 individuals with COVID, and they looked at follow-ups, and they looked at follow-ups to COVID to follow-ups to people with flu. And they made a comparison and identified at least 9 different symptoms that were more unique to COVID as opposed to people who've had flu. These symptoms, prolonged symptoms, have been shown to be abnormal breathing, abdominal symptoms, chest, throat pain, discomfort, cognitive problems. You may hear about the term brain fog, excessive prolonged fatigue, chronic headaches, muscle pain, joint pains, anxiety, and depression. So what the study had outlined is that 37% of patients had at least one of these 9 symptoms. What I find interesting is that as they started looking a little more closely, and if you look at the bottom, you'll see that women and younger people were more likely to report headaches and muscle pains as their long-term symptoms. Women were also more likely to have abdominal symptoms and anxiety and depression. Men were more likely to experience breathing difficulties and brain fog. So you can see there's no one particular symptom that you could really hang your hat on, because everything was going to be different. But individuals who've had COVID, there's a good chance that there may be some lingering effect with people. Now, the downside is that there is it's an ongoing research as to figure out what can help alleviate these symptoms for these long haulers. And so there's studies that are going to be ongoing for, months to years now as to what is the best clinical approach, diagnosis, also treatment plans for individuals who get COVID. So these are, some highlighted things that have come out, a lot of things in the last 2 weeks. And so it's important when we start talking about COVID and how we look at prevention and looking at how this mandate of vaccine is going to impact all of us. It's really looking at what's the ramifications of actually getting COVID. And it's not as straightforward as people think, like, oh, if I get COVID, I get recover, I'll be all right, I'm young, I'm healthy, and so forth. But there's a chance coming out of getting COVID that you may have one of these long chronic problems. And so not getting vaccinated with the risk of not just hospitalization, fatality, but having a prolonged course of a symptom really doesn't sound all that appealing at all. So looking at what's going on now when it comes to vaccinations here in Milwaukee County, we have a clear distinction of rates of vaccination by race and ethnicity here in Milwaukee County. One thing I want to focus on today is looking at the incidence rates, particularly over the last 2 weeks. As you can see here, this is a heat map, red being high concentrated areas and rates of individuals per 1,000 who are being diagnosed with COVID. And you just see a very broad, diverse rates of infection that are ongoing. You have a very clear, highly concentrated area on the north side, and when you get further south in Oak Creek and Franklin, and Greendale, you see that there are other high focal densities as well. Now, that's looking at all ages. So if we look a little more closely, let's say at individuals on the right-hand side, ages 0 to 17, and we start looking at, we hear about cases that are going on, particularly in younger people. So this is Milwaukee County looking at the latest or the last 4 weeks of cases of COVID. And again, there's very similar overlaps between these focal areas. So we have Oak Creek further south, okay, but the vast majority of new cases are concentrating on the north side as far as north as Brown Deer and River Hills. So a lot of new cases are occurring in these, and as you can see in these heat maps. So what's going on here in the state of Wisconsin, we see the single dose rates for individuals all ages 12 and up, 53.7%. For just 18 years of age and older, it's at 64.4%. Now, there's been the effort and messaging has been to get as many people vaccinated as possible, certainly in light of all of the national public health efforts and the current administration wanting to get people vaccinated, as well as going back to school and the FDA approvals. And so all of these new occurrences that have happened hasn't shown to kind of reverse this effort to get more people vaccinated. In fact, the number of individuals that are getting vaccinated is actually declining. As of September 29th, 5,500 new individuals being vaccinated on the average every day. That's less than 2 weeks ago. So efforts right now aren't working to elevate those rates right now. So if we look more specifically at single dose 12 years of age and older, specifically at the racial and ethnic comparisons, we see the numbers there. Over the last 2 weeks, the number of new vaccines per week is actually declining, and it's declining across the board for each race. So the effort to bump these up is just not, we're not seeing it. It's just not occurring. So if we look a little more specifically at the 12 to 15-year-olds and the number of new doses being administered for this age group, again, we see that number declining. And this is almost in complete opposition to what the numbers are actually showing of new cases. And I'll get to that soon enough here. So only 357 new vaccines are given on the average for 12 to 15 years of age. I brought this up a couple of weeks ago, and again, this is really just looking at individuals, the rate vaccination in the state of Wisconsin, and comparing rates of infection to people who've been vaccinated to unvaccinated. And you can see by this charting that it is you're 3 times more likely to the rates is 3 times higher in unvaccinated to vaccinated individuals. And if we look more closely at demographics, age demographics, we see the rates of each demographic that are vaccinated. And when we look at the case rates of people who've been vaccinated to unvaccinated, you can see there's just a huge difference between the people who are vaccinated to unvaccinated and getting infected. And so sometimes it's maybe as high as 10-fold. So we know vaccines work. Okay. We know that unvaccinated, especially with this particular variant, are even at higher risk of not only being ill, but even having a fatal outcome. We look at what's occurring throughout the United States, where we are right now. If we look at the total population, percent of total population fully vaccinated, that's 55.5%. If we look at just 18 years of age and older, 66.8%. So that's fully vaccinated. Those are the markers that people should be looking at. It's not just a single dose, it is looking at fully vaccinated. That's when people have full immunity after being fully vaccinated. So just like I mentioned, what's going on in Wisconsin, much of what is going on throughout the United States. We've had all of these interventions, FDA mandating announcements of vaccines, and that rate just hasn't picked up. In fact, it's actually going the opposite. So on the average right now, 587 vaccines have been given out on a daily basis. And you can see that that rate appears it will continue to decline here. So what's going on with the native populations in Michigan, Minnesota, Wisconsin? In that middle column on the left-hand side, you see a number. That first number is the total number over the last 2 weeks, and the average number, the second number there, is the average number of cases. And what's kind of really surprising was Minnesota had a huge bump, almost a twofold increase in the number of new of COVID cases over the last 2 weeks. And that is alarming, because I hadn't seen a number like this in the state of Minnesota. Even in Wisconsin, I have not seen a number this high in such a short amount of time. So in the state of Minnesota, it is quite evident that COVID is really running rampant through that state. Wisconsin, you see there's 403 cases, 202 on the average over the past 2 weeks. So it is definitely impacting natives in the Bemidji area right now. We look at the state of Wisconsin as a whole, the average, 7-day average is 2,416 with 2,340 new cases as of yesterday. I think the upside to that is that the average rate is starting to decline. And in the past 10 days, that number compared to 2 weeks ago is starting to show evidence of declining. So it's quite possible that Wisconsin may have reached its peak, and we are now looking at a trend in the right direction. So I wanted to bring up one particular point, because I think this ties into the whole vaccine, particularly with kids, as we move forward, how much it's going to be important and what this looks like for the native population. So we know that in the state of Wisconsin, natives have the second highest case rate for COVID. second highest rate of hospitalization, and the highest rate for fatalities. Now, something has turned and changed in the last 2 weeks. And when you follow these numbers, you can see that these are, as a line graph here over time, the orange is our native population. So over the last couple of weeks, the native population has been in parallel to the African American population, and it's only been in the last couple of days where the native population has the highest rate, as of right now, has the highest rate of new infections for individuals that are 18 years of age and younger. And this is a new dynamic that's occurred. And when we look at, does that necessarily translate into hospitalizations? And the answer is no, it hasn't. So even though there may be a higher rate of new cases occurring in Native communities, particularly young people, it's not translating into higher hospitalizations. So if we look at comparing Natives to other races, we see that the rate is 13.6 per 100,000. But that rate, even the slightest of cases by 1 or 2 can dramatically change that rate. And we're seeing that there's been only 2 cases of individuals less than 18 that have been hospitalized in the past 2 weeks. So now, along those lines of young people, young Natives getting COVID, we see when I look at the numbers over the past 2 weeks, the numbers of new infections, the new age group, isn't the 20 and 30-year-olds, it is now the 10 to 19-year-olds. They are the highest group in the state that has the most cases, followed by the 30-year-olds and then, the 20-year-olds. So that younger age group is definitely has the highest rate, and they make up 43% of all of the new cases that are occurring right now. Because we've had our older population highly vaccinated, and with each age group going down, that rate declines as well. But with that younger age that are less vaccinated, they are, as a result, making up a good portion of all new infections. And so that's why it's important when we look at vaccinations, we see that younger age groups are now becoming the most predominant. And so that's going to be an important point moving forward. So a lot of information I know I gave out there. I'm trying to get this out as best as possible. And I'm going to turn this over to Mark or Jeremiah for any questions.
Right, I'll ask a first question, and we'll go over to Jeremiah's question about Moderna and Pfizer. And if anybody has a question, you can put that in the chat box. That's fine to do that. So kind of a couple things. One is our average age in the United States for Native Americans is 31. So what you just related, being that younger group, getting that high, being number 1 for Native folks and with infection. And then kind of the second group, but being over 30, that 31 and on, that all squares with our demographics. So that the reason why I say this is the information you're getting here relatives is factual, and once you start seeing it, these things line up. That's why it can begin to depend on the information we're trying to share with you. So here's kind of where this question is leading. Just recently, just yesterday, I think it was Disney in, where was it? New York City shut down Aladdin of all things. They test people every day. They said, hey, we have an outbreak here, breakthrough infections. They test their workers on that Aladdin production, I think 6 times each week. So certainly they're doing a good job and they have a sense of what's going on. So here's the question parents and teachers, kind of ask. Let's say you have a class of 30 kids, and kind of when you're having conversations about COVID-19, what kind of, as it would raise your concerns? Now we're talking in that 5 years old to 12 years old, so they're not able to vaccinate. Schools are kind of left on their own to make this call, but in that classroom, in 5 to 12, 30 kids, how many infections before that classroom needs to be shut down, or do you even close it down? What are your thoughts about that?
Yeah, that's a good question, and I feel that it's there's no clear answer. I know people talk about percent positivity, testing rates, and the transmissibility, the level of transmissibility within that county. This is going to be a tough call, no matter how you cut it and how you slice it, wherever you look. It really is going to be a general sense of how this is trending in a classroom. I think the decision would be, let's say, suddenly, 4 or 5 kids out of 30 in one room all have called in because they're sick. I think there's a pretty good chance that there's going to be even more of cases coming out of that class. The isolated cases of 1 or 2, these are kind of manageable. These are manageable. I think when you start getting a little higher, 4 or 5, even higher, the cat's already out the bag, and the risk of more being infected is going to go up. I think there's better chances of isolating a single case in a classroom, or even 2, if you know the circumstances, like, hey, little Johnny and Mary sit at the same table, kind of thing. That would be a pretty easy thing to know that, yeah, they got it from one or the other, and isolating or removing, quarantining, stay at home would be, maybe just enough to prevent further outbreaks. So it's a tough call going from, I know there's different requirements in school districts. It really is going to be a judgment call. At what level do schools, what level do they feel comfortable in managing?
Just a follow-up question to that one, and Jeremiah, will turn it over to you. And this one was from a teacher, unfortunately last week, but here's my chance to ask it, because I think the question's still out there. They're in that classroom of that 5 to 12 years old. Mm-hmm. They're sending notes home to parents as they can if they find out a child has COVID-19. So the teacher's question is, they're in a school where it's kind of mask optional for the teachers. What would you say to that teacher that's teaching that 5 to 12-year-old unvaccinated group as far as wearing a mask during their workday and working with children in that classroom? And Jeremiah, will go to your question right after this.
So I think there's a good level of reassurance that if the teacher is vaccinated, I think a lot of the studies that have come out of the clinical trials and follow-ups that have occurred, not just here in the United States, but throughout the world, that effectiveness of that vaccine is actually really, really good. I know they talk about diminishing, but I think when you look at diminishing, going from 95 to 85%, yeah, that's a diminishing effectiveness. A slight one, but if it went from 95 down to 35, yeah, I'd say that is a clear indication that that these vaccines aren't holding. So do keep in mind that vaccines certainly do provide a level of effectiveness in prevention. Now, individuals who are vaccinated, as I showed, the rates of infection are certainly dramatically much different and lower than people who are unvaccinated. And we know that individuals who are vaccinated there is a chance, 10% chance that yes, you could become ill. But that doesn't translate in severe cases of hospitalization or even fatality. So keep in mind that that level is of protection is still there, and it's still quite effective. Now, I think as far as choice, as a physician, I wear a mask every time I am in close contact or in a face-to-face interaction. Even if I'm not in an exam room, I still wear a mask. When I know there's patients and other people always around me, I wear a mask in those encounters. So, and I even see people who are ill who may not necessarily look like COVID, sound like COVID, maybe they got something else. I still wear a mask, and I still feel confident in that protection. So I think if you want to feel a higher level, wearing a mask would certainly even reduce your risk even further. So.
Right, Jeremiah, we're going to go over to you for the last question today. And for those of you that may not know it, there's a lot of things happening at the Gerald L. Ignace Health Center. One of them that I really like to see was a tree that was put up on a wall about that issue of suicide in our community. And for those of you active in our Milwaukee community, within the last few weeks, we've been kind of rocked by it, and it's not going away. So more of these kind of prevention and awareness sorts of activities are really needed. And we also need to be asking questions of those who are in mental health doing presentations on this Orange Shirt Day. And I'll say that we have universities doing presentations about how they're to be aware of what happened in residential schools, but yet not talking about what they're doing for university students today who are affected by the historic trauma that descends from those boarding school experiences. That's why this kind of show is important. Rounding this back to this COVID-19 program. We're here to talk about an issue that's facing our community. We're doing it in real time, and we're not running from those real questions. So if you have a question, even offline, please get a hold of the center, and we'll try to address that as best we can. So with that, I'm gonna turn this back over to Jeremiah. And guys, do me a favor as I'm signing off here. It'd be awesome if you guys could put 3 ribbons on that tree for my family. We'd appreciate it, and that'd be awesome. I know that the last day to do that is today, and so 3 of them on there, man. That'd be all right. Jeremiah.
Thank you, Mark. Yeah, I just had we went through the kind of booster, a whole rigmarole of what's going on with that, and I just wanted to, a lot of us out there, a lot of people out there got the Moderna vaccine, and none of that there's not being really mentioned due to the fact that pretty much everything is Pfizer at the moment. So do you see any reasonings behind why kind of Moderna has been lagging behind in approval or okaying a booster utilization for their vaccine? Is there a belief from them that their efficacy was higher, or maybe a booster is just not needed? So I'm just just curious, for those who maybe received the Moderna vaccine, and then maybe they're sitting there saying, well, why is this putting me at the back of the line?
Yeah, no, that's a good question, a good point, because, everything has always been, Pfizer was the first to come out, first approved, first everything, and Moderna has kind of had to take a back seat to Pfizer in that regard. But it doesn't necessarily mean that Pfizer has lagged in its same information that is being submitted to the FDA and CDC. There's a couple things that have come out with Moderna, and I find it to be a little interesting because when Pfizer and Moderna both came out, they're pretty close together in time in terms of them coming out and giving their information and their clinical effectiveness, and they pretty much had very similar data points, very similar in comparison. And one wasn't any more efficacious than the other. They were compatible in just about every category. What I find interesting now, and maybe an indication why Moderna isn't so readily forthcoming in trying to get ahead of Pfizer, is that the trials, follow-up trials that are coming out is actually showing Moderna having less of a decline in its effectiveness, meaning that not only is it's outlasting Pfizer's effectiveness over a longer period of time. And so that, I think that may change the trajectory of Moderna and its effort to push boosters for Moderna. If Moderna is going to be longer term more effective with little diminish in its effectiveness, if I was Moderna, I probably wouldn't feel the need to push Moderna to be a booster. And so, that type of information has come out. And it has shown to be effective against Delta as well. So, these are two variables that are coming out that have shown to be better long-term than Pfizer. I can see Moderna not feeling the need to have to get out way ahead to do that. So, if you look at hindsight is 2020, you could look back, should I have waited, I get people who've gotten Pfizer, who wanted to get it and demonstrate, should I have waited for Moderna? There was no way to know that. And looking at it now, people who got Moderna may actually be a little better off than people who had Pfizer. It may mean that people who got Moderna may not actually need a booster. But people who got Pfizer may very well. And people who got Johnson & Johnson may need to have a second shot. So, this is what's going to make this a bit confusing moving forward, because, there's going to be splits. There's 3 types of vaccines in the US, and each one is going to have its own pathway and guideline of recommendations on how to move forward, especially with the booster. So I wouldn't take what's occurring with Moderna. I wouldn't take that in a negative light. I actually, looking at the information that's coming out, I'd look at it as being a positive to people who've gotten Moderna.
All right, thank you, Dr. Nace. That really definitely helped out and answered that question for me. With that, I'm going to give it back to you, I guess. And if you have any final words for the audience today, and otherwise we'll see everybody again in a couple of weeks.
Yep. No, lots of information out there for everybody right now, and it's hard to take it all in if you're not fully honed in on this. But the takeaways today: high rates of infection in younger people. Vaccines for 5 to 11 are going to be coming available, hopefully between or at least shortly after Halloween, but before Thanksgiving. So this is encouraging news. It's going to be important moving forward that these vaccines, especially in the younger population, is who would greatly benefit the most when it comes to rates of infection, because that's who we're really seeing most of the new infections. And so this is going to be a decision, again, family decision as to how to move forward and what would be the best course of action for protecting not only yourself, your spouses, and your significant others, and as well as your kids. This is going to be important decisions coming in October, without a doubt. Now, I did want to highlight one other thing before I go. Please check us out on our Facebook website for November 5th, our Honoring the Heartbeat Mental Health and Wellness Mini Powwow. We do ask that people show proof of vaccination and a negative COVID test 72 hours for your participation at the Potawatomi Hotel and Casino. So that is an upside that I think that we're going to be looking at better numbers moving forward in the month of October. And one, I think that at some point we will see that Delta has peaked, and we are inching our way out of this pandemic, and which is going to be encouraging news moving forward, and hopefully that happens in and around Thanksgiving time. So, but until then, and next time, everyone, do consider getting a vaccine, and I will see you in a couple weeks. Stay strong.